Good morning. I'm Dr. Rutledge, and we're going to talk about three topics today. One is failure, the second is power, and the third is success. We're going to talk about the failure of diet and restrictive procedures to treat morbid obesity. We're going to talk about treating the underlying cause in a powerful way by looking at the neurohumoral effects of surgery. And we're going to talk about the success of the mini-gastric bypass. And so we'd have those three topics I'm going to bring forward this morning. First, I'd like to express my honor and appreciation of my host country, that is India. I'd like to recognize the languages, culture, the ancient religions, and of course the people of India. Strong, resolute, industrious, and free. My honor to the country of India. I'd also like to express my sincere thanks to my host, Dr. Kular, and I would like to point out that I've had the good fortune to work with surgeons all over the world. I have visited and trained with surgeons in many states throughout the United States, from Florida to California. I've operated throughout Europe as a teacher and visiting professor, from England to Italy to Turkey and in various other cities in India, and I would like to compliment Dr. Kular and his hospital as one of the best that I have seen in the world. So thank you, Dr. Kular, my host. Let me give you a little bit of background. I trained in particular in medical school with Dr. Lester Dragstadt, and that's important because of his aggressive investigation of the areas of gastric physiology and the vagus nerve. But also, interestingly, Dr. Dragstadt taught and told us about his experience of bringing forward his signature operation called the vagotomy and pyloroplasty. And for those of you too young to remember, peptic ulcer disease used to be a surgical disease and was one of the most common reasons for operation in the United States and the world. And peptic ulcer disease now has been very successfully treated by the H2 blockers, Tagamet, cimetidine, and now, more recently, of course, the PPIs like Prilosec or omeprazole. But prior to those developments of those drugs, ulcer disease was a very serious problem throughout the United States, and the treatment was highly controversial, not really unlike the controversy we see today in bariatric surgery. So many surgeons were strong advocates of the antrectomy and Billroth II, and others were advocates of a new operation called the vagotomy and pyloroplasty, which was really invented by Dr. Dragstadt. And just to let you know, the controversy is not new in surgery. There was intense, bitter, and rancorous debate about the appropriate use of different types of surgery. And I can say that I honor Dr. Dragstadt in his strong fight to support his new operation, and it was ultimately vindicated, and it was shown that it was clear that his operation was a good one. So, interesting parallels come up in people's lives. I've also spent 20 years as a resident, assistant associate, and full professor at the University of North Carolina. My specialties were trauma and critical care. I was chief of medical informatics. Spent 20 years in trauma surgery, and I was director of the North Carolina Trauma Registry and wrote the software for that program for 10 years. Also have an extensive background in peptic ulcer surgery before the onset of the Tagamet and PPIs like Prilosec. So I have a lot of experience in ulcer surgery, including the primary ulcer surgery that we did in that time period called the antrectomy and Billroth II. And I know from personal experience in many cases that it's a good surgery, although it's not perfect. I also did a vagotomy and pyloroplasty, as my teacher, Dr. Dragstadt, taught me. I've been in bariatric surgery for 35 years and did training and then participated in open Roux-en-Y and vertical banded gastroplasty with my teachers at the university there, Dr. Herbst and Dr. Buckwalter, who are prominent in the history of bariatric surgery. 1997 was one of the first persons in the world to do laparoscopic Roux-en-Y gastric bypass, and now have performed over 6,000 cases of mini-gastric bypass and been fortunate to be invited professor to operate and teach in India, Turkey, England, Austria, Germany, France, Italy, Czech Republic, Spain, Portugal, and Mexico. So that's my background to bring to the presentation this morning. If you're considering the mini-gastric bypass, we think it's a superb surgery, but there are some tricks and traps to managing that. And so it's important that if you are thinking about considering the mini-bypass, that you get safe and careful education on using and applying it. My goal today is to teach, if possible, but I think my responsibility is not to bore you. Ideally, I'd like to entertain you, maybe with a little smoke and mirrors. I think of myself in some ways as kind of a dancing monkey, in just a moment to induce maybe a touch of fear and laughter, and hopefully you'll learn something from the presentation. Let me start off by saying that India faces a dangerous new enemy, and the surgeons of India know this, and that is diabetes and obesity are growing rapidly. India will soon have more diabetics than any other country in the world, so it faces a very difficult problem. And so the question arises that we will address this morning is, who will come to India's aid? I'm going to start off talking about the past history of the failure of restrictive procedures, and that includes the horizontal gastroplasty, the ring gastroplasty, the vertical banded gastroplasty, which I did, I think hundreds of, the lap band, which India has recognized as a complete failure and is essentially not done in India, although it's still popular somewhat in the United States, and the rise of a new popular restrictive procedure, and that's the sleeve. And we'll talk about how it's going to be pretty obvious how those things will fail, and similarly why diets fail. And then we'll talk some more about other more powerful and durable solutions. This is just a 2012 article. It's a growing number of revision procedures are to be expected from failed restrictive procedures, such as the band, the vertical banded gastroplasty, and the sleeve. And in fact, also just published this month in Obesity Surgery by Dr. Gautier in France, they reported 18 recent failures of sleeve that were so severe they required conversion to Roux-en-Y bypass. Of the group, it's important to note, and we'll talk about this later, that 30% had revision because of severe GE reflux. And also of note is the fact that the time to failure was extremely short, less than 24 months. So we're seeing restrictive procedures, as they have in the past, beginning to fail and failing soon after the operation is performed. Now, as a background, I'd like to talk about obesity and point out that many people think obesity is simple, just calories in and calories out. And if that's the case, then eating less and exercise more should take care of it, and so a diet theoretically is all that's really necessary. Unfortunately, the research shows that thousands of diet studies have a success rate of under 90% in the first year and under 95% failure rates just as simple as eating less and exercising more, because this is an intellectual attempt to overcome a powerful, primitive neurohumoral system, which is the drive to eat. Willpower routinely fails because it's coming up against this primitive set of hormonal reflexes that drive us to eat. To think of how this works, think of breathing. Breathing is also controlled by a set of primitive, deep, powerful reflexes, which we do have some intellectual control. So for example, I could tell you to hold your breath. But after a period of time, a minute or a few minutes, your intellect, no matter how powerful your will, no matter how intelligent you are, will be overridden by this powerful, deep neural system which will force you to breathe. You will have to give up holding your breath. In the same way, we would like to point out the research suggests that there is this powerful neurohumoral system that drives people to eat, and by intellectually deciding to eat less and exercise more, research studies suggest that You cannot overwhelm this with a diet and exercise program. This is what the scientific research says, despite common sense, which would suggest all you have to do is push back from the table, eat less and exercise more. The outcome of both diets and restrictive procedures is weight loss followed by weight regain. And we think that's again explained easily because the underlying hormonal system hasn't been affected. Restrictive procedures have an interesting approach in that they create a mechanical block to the eating of most normal healthy foods. So if you eat an apple or a piece of broccoli or a piece of steak and swallow it into the upper part of a band or a sleeve or a vertical banded gastroplasty, that will often cause the equivalent of if you had swallowed a cork. And then there's this terrible feeling of pain and retching and struggling until that is finally expelled or digested, which can be a very, very painful and unpleasant experience, I can tell you from hundreds of my patients. Now, the patient wants to eat right, knows that broccoli or a sandwich or an apple or a piece of steak is good for him, but over time there is partial obstruction, reflux, vomiting, and the reflux may lead to severe reflux and chronic reflux, which we know is associated with esophageal cancer. So again, what happens? Weight loss leads to increased hunger. In other words, like holding your breath leads to increased drive to breathe. There's also a decreased satiety, so that when you eat something, the research has shown that you're less able to stop eating, that is satiety. Healthy foods are blocked, the drive to eat is up. What can you predict in this case will happen? Well, we know what will happen, and that is the patient will be driven to calories to breathe, to allow him to eat, that can go through the block. Okay, and that's easily available. You try to eat an apple, it won't go through the narrow band. You try to eat a sandwich, it will have difficulty going through the narrow sleeve. You try to eat broccoli, that's coming back. So these restrictive procedures do successfully block these components of a normal healthy diet. But it's important to point out they do not block ice cream. They do not block candy bars. They do not block Coca-Cola. 200 grams of ice cream, 540 calories. 2 Milky Way bars, 1,000 calories. A 2-liter bottle of Coke, 800 calories. The lap band, the sleeve, the vertical banded gastroplasty does not inhibit any of these. So patients with restrictive procedures can easily get 2,000 calories at a sitting. And during a day, easily 3,000 and 4,000 calories are within reach. So obesity then returns. Restrictive procedures then perform a mechanical block, but you need to attack the underlying drive to breathe, the drive to eat, this very primitive and very powerful drive. And in the absence of that, patients with restrictive procedures will fail to eat healthy foods because the restriction is present, but there's a lot of high-calorie foods which go right through that restriction. Research also shows, as we can see in the slide, that the surgery and diet make you hungrier, so that you ultimately overwhelm the operative block or your desire to eat less. You say, I think I will eat less, and unfortunately the system is out of whack and demands that you breathe, demands that you eat, and you can't hold your breath, you can't diet on your own. In the case of a mechanical or restrictive block, those operations do create a restrictive block, but there's a way around it. If you're a sleeve patient, you probably don't want to listen to the rest of this because it's easy to beat your sleeve. That desire to eat that you feel is easily addressed. And as you get more and more weight loss, that research has shown the desire to eat will grow. And as it grows, you will ultimately find out the secret to beat the band, the secret to beat the sleeve, and that's Coca-Cola. You can easily get 4,000 calories a day in by drinking Coke. And the sleeve and the band do not stop that. Recent research has shown that a short diet, that is only 3 months, actually permanently derails the normal breathing system, the normal hunger system. I keep saying breathing because people understand, I think, the drive to breathe, maybe more than they understand the drive to eat, which they think is more under more intellectual or personal willpower type control. The drive to eat is damaged by dieting. A recent study just published shows that long-term persistence of hormonal changes occur after dieting. So that when you diet, the hunger hormone ghrelin goes up and the satiety hormones of PYY, amylin, and cholecystokinin go down. So people after a diet get hungrier, which I think most of us can remember any experience of trying to diet or just missing a meal. You get hungrier. And when you go to eat, the block, the end of the meal, the chemical system that says, okay, you've had enough, or to use that analogy of breathing, you can say, okay, you can slow down your breathing. Those chemical systems are damaged by dieting. And that damage occurs not just at 10 weeks throughout the diet, but it's been shown to persist for up to 5 years. And that's what's shown in this study here. So in summary, we could talk more about this, but I want to go on to talk about the mini bypass. Most diets and restrictive procedures are going to fail, and attempts to override the neurohumoral hunger system routinely fails when you use the intellect or obstructive procedures. And particularly resistive or restrictive procedures force the patients into pathologic dietary choices. So what is the solution? And the answer can be seen again from this graph we showed earlier. Here is the change in hunger that occurs after dieting. But this is from the same study in the New England Journal, and you can see that gastric bypass did not increase hunger. And so we have done a study of our patients that shows that mini-gastric bypass attacks effectively the neurohumoral system. The mini bypass is a short, simple, durable 30-minute surgery, and it decreases hunger. This is the results of our survey. Basically, it showed that when we ask obese patients to grade their hunger prior to surgery, they gave us numbers all over the map, but most people say they were pretty hungry. That is, prior to having surgery for obesity, obese patients, maybe not too surprisingly, said, you know, I'm pretty hungry, and I can eat a lot to go along to help address that. So they said, when grading it on average between 1 and 10, throughout the day, again, overall, they graded their average feeling of hunger about 7.5. And intriguingly, between 1 and 10 years post-op, we also asked the same thing. And what we found, in contrast to diet, in contrast to restrictive procedures, the mini-gastric bypass leads to a significant decline in hunger. So people go from very hungry to not very hungry. I mean, simple as that. And that's critical in successful therapy. Now we're going to talk a little bit, well, what do the experts say about these choices? We're going to talk about 2 restrictive procedures, that is the lap band and the sleeve, and we're also going to ask these experts about the Roux-en-Y bypass, which, although it's a bypass, many people don't declare it as a malabsorptive procedure. And then we're going to talk about the mini-gastric bypass in comparison to those 3. So we'll have 4 operations, and what we did is we turned to 100 surgical experts. So we said, give us your opinion about these procedures, and let us ask you some detailed questions. And that's what we're going to talk about here. We also asked them how frequently is diabetes resolved after the operation. About 1/3 of diabetics had resolution of their diabetes after the band, 59% after the sleeve, 64% after Roux-en-Y, and 86% the best with mini bypass. We asked if you had discomfort. Are you facing problems with having an upset stomach? That's dyspepsia. When we asked, the band had the highest rate of dyspepsia, 1/3 of patients. 22%, a quarter of patients with sleeves said they had dyspepsia. And the Roux-en-Y 5 and the MGB 6% had dyspepsia. So upset stomach goes with the territory if you have a restrictive procedure. We also looked at preoperative GE reflux, and Roux-en-Y and MGB surgery is often done for sicker and heavier patients, as it was in this series. And what we found is that the thinner, healthier, younger band and sleeve patients had relatively low rates of pre-op gastroesophageal acid reflux, between 10 and 11% for the band and the sleeve. The Roux-en-Y and the MGB had 17 and 19% respectively, so they basically operated on sicker and heavier patients. The remarkable change is that post-operatively, the sleeve and band patients increased the rate of reflux. So let me say that again. Pre-operatively, they had relatively low risk of acid reflux. And post-operatively, these rates doubled. So in the band, 24%, in the sleeve, 27% of our experts said that the rates of acid GE reflux increased and present in almost a quarter of patients. And it's important to point out, we know that GE reflux, acid reflux, damages the lining of the esophagus, and it's a very strong cause of esophageal cancer, which is growing rapidly throughout the United States and the world because of acid reflux. So a quarter of band and sleeve patients, and in some series up to 30%, are going to face significant acid reflux, and this is a risk factor for esophageal cancer. Again, intriguingly to us in the study, the post-operative rates of GE reflux in Roux-en-Y and MGB were low at 6 and 4%. So the band and the sleeve double the risk of GE reflux, up to a quarter, and the Roux-en-Y and the MGB cause a rapid, precipitous, and strong decline, going from 17% down to 4%. Then we looked at the primary goal of weight loss surgery, which is weight loss, and we looked at percent excess body weight lost by the different groups, by these experts. What did you think? Their estimation was the band had a 42% of excess weight loss, the sleeve and the Roux-en-Y 60 and 62%, and the MGB again was judged best at 78%. The converse of this is percentage of weight loss failure, and again for the band, high at 34%, sleeve and Roux-en-Y 15 and 12%, and lowest for the MGB at 5%. We asked how many lost more than 50%. Again, the same kind of trend, that is low for the band, 79 and 81% for the Roux-en-Y, but 95% best for MGB. Another important complication after any kind of surgery is bowel obstruction. The Roux-en-Y is probably known as a signature complication as bowel obstruction, and it's been reported up to 15%. In our survey, band patients had 0.4%, a relatively low incidence of bowel obstruction. No sleeve patients had bowel obstruction, but I think concerningly, the Roux-en-Y patients were reported to have bowel obstruction rates of 2.5%. MGB is also very low at 0.1%. So bowel obstruction, big, dangerous, and potentially deadly complication of the Roux-en-Y bypass that's different than the other types of weight loss surgery. The other difference is ulcers. The gastrojejunostomy, whether it's Roux-en-Y or Billroth 2, is likely to develop an ulcer. So that ulcer or irritation was listed for 0.9 and 0.3% of sleeve and band, and 1.9 and 1.8% for Roux-en-Y and MGB. So they are definitely our biggest concern over the long term. In my series, I can see up to 5% of our patients face this risk, and it's critically important, if you consider mini bypass, that you be well aware of this risk, know how to prevent it by avoiding smoking, NSAIDs like aspirin and Motrin, and interventions that are helpful, like the use of PPIs, Prilosec, and similar drugs, and the use of frequent oral intake of probiotic foods like yogurt. Another intriguing part of our questionnaire is we asked, do you think this operation is a short, simple procedure? And 82% of our surgeons said yes, the band is a short, simple surgery. 70% said the sleeve was, and 69%, about the same, said the MGB was a short, simple operation. No one in the series said that the Roux-en-Y was a short and simple operation. We asked, to kind of get another question, do you agree that the patients who have this particular surgery, the band, the sleeve, the Roux-en-Y, or the MGB, do you think they can expect to routinely get major weight loss if they have the band? Only 13% of surgeons said yes. 65% of sleeve surgeons said yes, 87% of Roux-en-Y, and 95% of MGB. Kind of the opposite of excellent weight loss is complications. So we ask the question in the following way: if people have this operation, say the band or the other kinds of operations, is it your opinion that they rarely suffer from long-term complications? So if you are offering a surgery, I think this is obvious something you would like to offer. You'd like to offer a surgery that rarely results in long-term complications. So then we said, do you think for the band, can you say that they would rarely suffer from long-term complications? Only 4% of the surveyed surgeons said yes, band patients rarely face long-term complications. The sleeve, much better, 52%. So at least half of our surveyed surgeons said if you look at a sleeve patient, they have at least an excellent chance of no long-term complications. 50% of our surgeons said that. But the flip side is that means 50% of our surgeons did not agree with that. That is, that they were fearful that patients who had a sleeve would face long-term complications. And we know that they do. In fact, by our reports, our surveys, as well as reports in the literature, up to 30% may face reflux of acid and GE reflux. And we know that GE reflux is associated with long-term risk of esophageal cancer. So we're talking about serious problems. Also, weight regain is common in many series, and as we talked about, there are series already being published on the short-term follow-up of lap bands going forward to revisions. Another concerning report is we asked that same question of Roux-en-Y surgery, and we said again, do you think they're rarely going to face complications? Only 39% of our surgeons agreed with this statement. And the flip side of that is that for the MGBs, over 70% said that they felt that the MGB patients would rarely suffer from long-term complications. Recently, there was a large series of sleeve patients where they analyzed dozens and dozens of studies, and overall of over 1,000 patients, the leak rate was 2%. And again, all of us, I think, realize how deadly and complicated a leak can be. Bands were listed in our survey surgeons at 0.1%, the Roux-en-Y was around 1%, and the MGB is less at 0.5%. So what can we say then in summary? In short, diet and restrictive procedures are likely to fail, often in as little as 2 years, and the restrictive procedures push patients toward liquid calories as a solution for the hunger which grows after the initial honeymoon period. Weight regain is common. Reflux can be reported in up to 30% of patients, and we know that's associated with a long-term risk of esophageal cancer. The mini-gastric bypass has been shown to be short, simple, safe, powerful, effective, and durable. It's my favorite choice, and we're seeing growing interest in the mini-gastric bypass around the world. Thank you for the opportunity to talk to you this morning, and I hope you found it enjoyable.